Presentation number 12 for brain neoplasm, prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be dealing with the deposits. Remember that hemorrhage, dense cellularity, and high protein, and as well as calcifications will appear all dense in CT and hypointense in T2. Remember also that most deposits start as solitary. 50% you can find only one lesion, and that cortical deposits will show minimal edema and need intravenous contrast. This all together should be correlated with the patient condition, patient diagnosis that malignancy is there. Remember that hemorrhagic deposits include thyroid, renal cell carcinoma, and melanoma and choriocarcinoma. And remember that intra-axial or extra-axial deposits are seen in breast and lung, while mainly intra-axial are seen in the melanoma and colon, and mainly extra-axial are seen in prostate and neuroblastoma. So to gather all together, metastatic disease, we should be concerned with the history of malignancy. We should know that most deposits starts as one, and that cortical deposits needs contrast because of the minimal edema, and that deposits with hemorrhage, dense cellularity, or high protein or calcifications will be presenting as CT dense lesions and T2 hypointense lesions. Hemorrhagic deposits are mainly seen in melanoma, renal cell carcinoma, thyroid, and choriocarcinoma, and I'll remind you about that renal carcinoma and thyroid carcinoma tend to send odd metastasis, and here is odd, they are hemorrhagic. Intra-axial, extra-axial deposits are seen in breast and lung, mainly intra in melanoma and colon, mainly extra in prostate and in neuroblastoma, as neuroblastoma tends to fill the sutures. Now this one here, flare with extensive edema, and on the right is T1 weighted image with enhancement. Deposits from cancer breast, edema surrounding the lesion within the left posterior frontal lobe. Contrast enhanced T1 weighted image show intense ring enhancement with central hypodensity. And irregular shape of the rim. It is not concentric smooth, but it shows some thickening and irregularity. Deposits from cancer breast, again we said here that cancer breast can show intra-axial or extra-axial, as well as the lung the same. So here it is intra-axial, here it is intra-axial with ring enhancement, but irregular rim of the ring, and here again is still intra-axial, showing nothing on CT plane, showing nothing or minimal hypointensity in T1 weighted images, ISO or minimally hypointense, but it may show the edema and the lesion in the middle in the T2 weighted images. In flare it will manifest edema, and after contrast it will show the enhancement of the lesions themselves as intra-axial lesions. In breast carcinoma, we said that it could be intraaxial or extraaxial, and here it's the typical leptomeningeal deposits of breast carcinoma enhancing, and this is the cause of enhancement of the leptomeninges, the presence of deposits. And here is the same in another case, flare and T1 weighted images. Not only the leptomeninges but also the calvarium. Here it crosses the bone, it destroys the bone, crosses the bone, and causes bulge on the surface here. And these are deposits of breast cancer, could be intraaxial and or extraaxial. The same will apply to lung. And in the lung we have deposits from lung cancer here as restricted diffusion, and here as contrast enhanced multiple intracerebral intracerebellar deposits. Here it is seedling along the meninges. Deposits from cancer lung, again enhancing leptomeninges. Mainly on the left side, and intraventricular lesions, and you know that ventricular lesions are considered extraaxial. So we have enhanced leptomeninges and deposits at ventricles from lung. We know now that lung and breast can do both intraaxial or extraaxial. Leptomeninges, ventricles, seedling, as well as intraparenchymal deposits. Enhancement is the rule, maybe ring, maybe homogeneous. Now come to deposits from prostate cancer. Usually it is extraaxial. Here it is. This is the key point, our key point, that from prostate it is mainly extraaxial. From neuroblastoma, as we said, due to the suture filling, it is extraaxial. So we have prostate and neuroblastoma, both are extraaxial deposits. Here it is. The mass is leptomeningeal as well as suprasellar mass. Here is intraventricular lymphoma, another appearance of lymphoma. As we said, it is usually crossing. And melanoma deposits is one famous for hemorrhage, and at the same time it does not show anything in CT plane or MRI plane, but after contrast enhancement you might find some faint ring enhancement, and it is best seen in T2 weighted images. Best seen in T2 weighted images as blooming effects due to hemorrhage. Again, melanoma deposits is seen in T2 weighted image as blooming, as low intensity focus, and you cannot hardly see anything, only seen in T2 because of the content. Deposits of the melanoma may show some contrast enhancement in contrast enhanced T1 weighted images. Still, hemorrhagic mets is not only melanoma but thyroid, renal cell carcinoma, as we said, can do, and these are the appearances in T2 weighted images and in T1 weighted images as subacute hemorrhages. And here there is, after contrast, there is some enhancement, some are enhancing. Now sarcoidosis is mainly seen here as prominent leptomeninges, enhancing the leptomeninges compared to the other side. This is sarcoid deposits Sarcoidosis is an inflammatory infectious disease with deposits with multiple lesions. Inflammatory infectious with multiple lesions. Biogenic abscess, differential diagnosis is a primary brain tumor, deposit, granuloma, radiation necrosis, and here the origin is coming from the ear. We should exclude such an appearance. The famous ring smooth enhancement is the characteristic appearance of the biogenic brain abscess. Biogenic brain abscess is well defined T2 hypointense rim with edema surrounding. In enhancement we have ring enhancement and diffusion weighted images and ADC map. There is definite restriction. Thank you.